We're here today to talk about partnerships. An African proverb says, if you want to go fast, go alone. If you want to go far, go together. We hope that in our discussion today, we will demonstrate our commitment to this principle. In our presentation, we will look at Victorian cultural diversity and explore in more detail how the HACC program has responded to the needs of the diverse population. Primarily, this has involved initiatives to improve access to generic HACC services. In Victoria, the core HACC services are predominantly provided via local government, state and NGO health services. Ethnic organisations don't provide core services, but are a significant provider of social support programs. We have formed a statewide partnership between the peak bodies of the Ethnic Communities Council of Victoria and the Municipal Association of Victoria, along with the Department of Health, who funds the peak bodies to provide leadership to our respective sectors and service providers. There is a collaboration between HACC service providers and ethnic aged care organisations that support and improved outcomes for culturally and linguistically diverse, or CALD, clients in Victoria. Now let's have a look at Victoria's culturally diverse population. Victorians come from 200 different countries, speak more than 230 different languages and dialects, and follow more than 120 religious faiths. A significant number came to Australia as refugees. First Europeans displaced during the Second World War, then refugees from the war in Indochina, and more recently refugees from conflicts in the Republic of the former Yugoslavia, the Horn of Africa, Middle East and Afghanistan. The graph you can see here is based on the Australian Bureau of Statistics population data. It demonstrates the diversity of the Victorian older population. The green bar there, you can see, shows people born in Australia. The blue bar shows people born in non-English speaking countries. The orange bar shows people born in overseas in English speaking countries. As we can see here, that as we trend towards an older population group, people from non-English speaking backgrounds represent a significant proportional percentage of the overall population in those age groups. And that's most prevalent in the 65 to 74 age group, you can see there. People from non-English speaking backgrounds experience the same issues as ageing as everybody else. Overlaid issues relating to culture, language and migration experience may lead to people from CALD backgrounds not accessing services, dropping out early before their needs can be met. There are different patterns in different communities. Some big issues you can see here listed on the slide. The three I would like to highlight to you are, firstly, many people did not learn to read or write in their native language. This means that some people miss out on receiving information even when it has been translated. Secondly, many migrants lived through the assimilation era, which focused on let's all be the same, rather than today's more multicultural approach. This can affect how comfortable they are in speaking up and articulating their needs. It may be easier to drop out and miss out rather than speak up. Thirdly, many people from our older CALD communities have come here escaping conflict. Post-trauma reactions can often emerge once a person is no longer in the structure of work or raising a family. Mental health issues can be common in these particular groups. The Polish community, for example, has done considerable research into suicide in the older section of their community.
Those of you who know Victoria well will understand that we have a very uniform service delivery platform where the councils are the major providers of the home care services, home maintenance, meals, the district nursing service in Melbourne and in regional centres, and the state-run health services in the rural areas are the major providers of community nursing, and the community health services are the main allied health providers. So it's pretty much the same in all the different parts of Victoria. The 55 ethnic and multicultural organisations heavily involved in social support services, particularly centre-based respite and adult day activity services. So from that platform, I guess the strategic direction of the state in the HACC program has been how to certainly over the last 15 years and probably over the last 25, has been to try and build the capacity in the mainstream core HACC services to properly plan for and appropriately deliver culturally responsive services to all the people living in the areas that they provide services for. The multicultural social support services have had a particularly strong role in providing information and education to their participants about how the HACC system works and how to access the service system more broadly. And in fact, a recent report from the Department of Health on social support services indicates what a strong role they play in that function. So the various reiterations or emphases of the broad strategy to improve everybody's cultural competence, earlier on it was called an equity and access approach, and that provided resources at a regional and local level to both, for every HACC funded agency to undertake cultural planning so that they were acknowledging the diversity in their catchment and the particular needs and barriers, working together with local ethnic organisations and certainly at a regional and state level resourcing other peak organisations to take a more statewide role. This, I guess, initially was more about networking and working together in that more amorphous way. Certainly over the last 6 to 7 years, there's been a much clearer emphasis on more formal partnership and joint projects. And that the first of those was called the Culturally Equitable Gateway Strategy, in which the large councils who had very diverse, or the largest numbers of people in the HACC target group from born in overseas, in countries that don't speak English, and the larger ethnic organisations with the bigger proportions of older people developed in quite explicit partnerships, and that was a very relationship-oriented project. People really getting to know each other, work together, sharing skills and knowledge, trying to understand the data, the access data. And of course, one of the things everyone found was that the data integrity wasn't that great, so there was a lot of re-emphasis on ensuring HACC assessment people do actually fill in what country people come from and what languages they speak, etc. But also trying to look at some performance measures for measuring access better, and a lot of just development of cultural competences in the staffing and in the practices of every HACC organisation, and in this case in particular with the councils. The morph of that, if you like, that was a lot of very rich building. The morph of that is the supported access pilot project, which in many ways has some similarities with the South Australian LINK model, where professional staff who are bilingual, working within the ethnic organisations, provide much more direct assistance to individuals who are having difficulty getting into the mainstream HACC services or have some particular issues about that. So that project's, I think we're about into the 3rd year of that. So they're the sort of the history of the different emphases, I guess, in that broad direction. This is just some of the data from the HACC minimum data set. It looks a bit blurred. I just need to explain to you. We've got 2 charts there. The first chart is it's about the services, and the second one is about the clients. So the first chart's showing HACC service utilisation, and the bottom one's showing number of clients. The first bar is the census data. So the blue is people from English-speaking backgrounds, and the yellow is people from non-English speaking backgrounds. And the three bars from the first are showing bundling of HACC service types. So the first one is the home care services that generally councils are responsible for. The second is allied health and community nursing, and the third is social support and PAGs. So what that's showing you is the proportion of people in the population, the first bar, and then the second is showing by first service hours and secondly clients, the proportions that are using the services in Victoria. This is high level data, so statewide Victoria, and what it shows is that certainly for the home support services and a little more so for the allied health and nursing, there is some under-provision there beyond what you'd expect. And then for social support, there's greater utilisation. They tend to be a lot more language specific and culturally specific groupings. However, it is important to say that this is a big improvement on 10 years ago. I don't have the chart from back then, but this is now getting nearer to what you'd expect to see if people were getting equal access. At the lower level of a region or a particular council area, and certainly across different groups, you do get a lot more variation than this, of course, or some variation. So it's by no way saying everything's hunky-dory. There's obviously a lot of improvement and gains still to be made, but generally this is a much better picture than it was some time back. And Sarah's now just going to talk a little bit more about the sort of partnership, not at the ground level, but at the area of the peak bodies, because we have had a state government in the HACC program who's been very committed to resourcing these partnerships and does provide resources at the local, regional and state level to work on these issues together.